Welcome to the Building a Successful Practice podcast channel, brought to you by the Foundation for Physician Advancement. FPA is a nonprofit built by Marney Reid and a collective of world-class surgeons to provide education and experience on the leadership development and practice management aspects of medicine. I'm Marney Reid, founding board member of FPA, and I hope you enjoy today's podcast with our incredible faculty. Hey, listeners, we have some amazing faculty tonight who are going to share their best practices, lessons learned, and next steps on how to partner with your hospital, health system, practice, partners, etc., to get the resources you need. We've purposely gathered surgeons from different health systems, tenures, and subspecialties to round out the conversation so you really can take home practical and actionable tips. First, we have Dr. Amy Trammel, an early career hand surgeon at Atrium Musculoskeletal Institute in Charlotte, North Carolina. And we have Dr. Dustin Massel, also an early career surgeon, building his orthopedic spine practice in Skokie, Illinois at North Shore, which is part of Endeavor Health Medical Group. Dr. Carl Herndon, who is building a flourishing total joint arthroplasty practice as faculty at Columbia University Irving Medical Center. And last but never least, Dr. Bryan Springer, who spent 17 years at Ortho Carolina, who was recruited back to the mothership, as I say, and is the active chair of the Department of Orthopedic Surgery at Mayo Clinic in Florida. Hey, everyone.
Hey, Marney.
Hey, Marney. Thanks so much for having me.
Hey, everybody. Thanks for having me.
Hi, everyone. Thanks for having me. Glad to be here.
Okay, Amy, you recently submitted for part 2. For those out there who are listening and don't know, part 2 is just the oral boards part for orthopedic surgeons to become fully board certified. And you're really establishing your flow and the brand in your community. Has there been anything that wasn't available at your system before you got there, or that you weren't able to get right before you arrived and you're now asking for it?
So I was the first hand surgeon that my practice hired. So I think that there were probably a lot of things that weren't available that had been available to me as a trainee, because as you're training, you are at academic centers where everything's available. And then all of a sudden you take your first job and it might not be the case. So I tried to approach it first by just seeing what was there and using that. Because as a hand surgeon, other than maybe a microscope, which I don't use a ton of, I think that you can kind of use any retractors that are available, or maybe it's not the certain type of, maybe you like Littlers instead of a tenotomy or any other said small scissor. So first I just tried to use what was there. But then as I became more established and got a lot busier, there were a few things that I went to administration for and asked for. I'll give you my successful things first. One was as simple as a hand table. So the patients didn't have to be moved onto an OR table. I went to the administration and basically told them that I thought a lot of time was wasted on my short procedures of having to move the patient from a stretcher to an OR table and then back to a stretcher. And I thought it could be solved by getting a simple little hand table, and they agreed to it. And then everyone was so happy. All of a sudden, everyone wanted to be in my room because they never had to move a patient. So that worked well. And I think it was just explaining of that it was for everyone in the room, the patient, and more efficiency, not to like make my life easier. So that went over really well. I also asked for an occupational therapist once I had been in practice for a while. And by a while, I mean like almost a year. I explained how hard it was for the referrals team to get my patients over in a timely manner to an outside occupational therapist, and that I was worried my patients weren't being taken care of. And they were really receptive to that too. So those are kind of my 2 success stories. I could probably list a lot of things that I asked for that it didn't work out so well for, but I'm so new that I still think that there's time in the game to get that stuff. But I think the best way is just go about either are you helping the patients or helping the system be more efficient. I don't think that they would respond if I was like, hey, help me get home quicker. I don't think that's a good reason.
Yeah, I'll echo that, Amy. I think you're really smart and really astute observation to advocate for things that can directly impact either the flow of the day or the bottom line of the hospital. If the hospital can do a couple more cases and you have a thing that you want and you can couch it in that way, I think that's a really good strategy. And then in terms of staff and getting FTEs of whether it's an occupational therapist, like you mentioned, or an NP or a PA for your own practice or whatever that is, something like that prevents leakage of patients, improves patient access to care, improves patient experience of patients that are coming to your hospital center or your practice or your university, wherever you are, I think those are things that are generally fairly easy to sell to the administrators in the hospital because those are also aligned with their goals.
I would just add, credit to Amy about being thoughtful in this process, right? I think we've all seen new partners, new hires come in right from the beginning, kind of guns blazing saying, I have to have this, I have to have that. I can only do this procedure if I have this, right? And not really reading the room, understanding what it is really like at the institution or the practice that you're going to be at. You may be surprised that they have a lot of things that are comparable, but the worst thing that can happen is you go in, number one, requesting all of this stuff, and then your practice changes and matures a lot within the first year. And then all of a sudden you've requested this, big piece of equipment, the hospital's being a good partner and bought it for you, your practice was, and then you never use it. So I love the thought of kind of give yourself that first year to get comfortable within the practice, really get a good sense for what they have, what they don't have. And as your practice matures after a year, then I think everybody feels more comfortable, both as the surgeon asking for equipment and as the hospital or the practice saying, okay, now that we have a year under our belt, it makes more sense to partner and get these things that it looks like you really do need to help build your practice, as opposed to coming in from the beginning saying you need all of these different things.
I love that. Dustin, there are so many ways to perform the same spine surgery. I'm referring to everything lumbar that ends in lif. And there's a lot of equipment required for cases based on the patient, how you trained, et cetera. Can you walk through what you asked for before you arrived, if anything, how that went? And then did you also wait for a year, or have you asked for anything recently?
That's a great question. And I'm going to branch off of some of what Amy mentioned. I think there's a huge advantage of starting your practice complying with the hospital system and being able to use the equipment that's already available for you. However, I also got one of the best pieces of advices that I received from a fellowship mentor, which was minimize the number of variables that you have in surgery and attempt to do the same thing every time. Our joints colleagues can probably speak to that a little bit further, but surgery, building a practice, it can be incredibly stressful at times, especially in the first few years. And one thing I wanted to do when I came in was to minimize the cognitive load that I had for my surgeries. It ultimately benefits my patients. So one way I accomplished that was by making sure that my hospital was equipped with the technology, the instrumentation, most importantly, to help me accomplish those goals in surgery. And so I was trained at Rush. I used minimally invasive spine surgery techniques, all of the lifts. And some of those techniques were lateral lumbar interbody fusion, minimally invasive tubular decompressions and fusions. And I wanted to make sure that I had those equipment so that I could perform those surgeries most comfortably. Now, I could have always reverted back to the gold standard open surgery. However, one of the goals of my career is to develop an exclusively minimally invasive practice for the patients that are capable of achieving that. And so I asked for the instrumentation that would allow me to achieve that goal and to do so more readily.
So two things, how did that go for you? And the second one is, Bryan, are you currently making sure not to ever hire someone from Rush?
No, I wouldn't say we've gotten that far yet.
When I started out, I think that the ask for myself was two specific instrumentation companies. It wasn't a large purchase. It wasn't new table or a new O-arm. It wasn't a new type of massive capital expense. It was allowing several companies to come into the hospital system and to allow me to use that equipment, which I had utilized in my fellowship and residency and was very comfortable with. Recently, I have asked for new technology, something to put us a little bit further along in the cutting edge space of spine surgery, that being endoscopic spine surgery and augmented reality spine surgery. And some of those have gone over smoothly, and some of them have gone over with a little bit more hesitation. And so I think that I've seen it from both sides, where they were really accommodating for some of the equipment that I wanted, but the capital expenditures require much more utilization and much more thought from the VAC committee or something like that in order to get that equipment into the hospital system.
So I don't know how it is now, but 900 years ago when I was a surgical device rep and I was trying to get both capital and disposables into health systems that had never heard of my technology, what I found was they got a lot more comfortable if more than one surgeon was trying to bring something expensive in, unless they were either at the end of their budget year where they needed to spend it or they would lose it for the next year. In other words, they couldn't ask for that much money. So they would just start buying things, or they could really, really market it, because I think certain health systems or maybe even administrators, if they've come from other places, have gotten burned on big pieces of capital. So I don't know, I'd love to hear Bryan, Carl, Amy weigh in on that, but I had luck going around and getting several surgeons saying that they wanted to use it. That way the administration would know, to the point that was made earlier, that you're not going to get a huge thing brought in and then stop using it because your practice changed or whatnot.
That's right, Marnie. I think that, doing it as an individual sometimes can be challenging, especially if it's a large capital outlay just for one surgeon. But if you have a group and you can show that there's value as to why you want that, and it's not just one person in that group, I think that does carry a little bit more weight and a little bit more credibility.
I totally agree. The other thing, Marnie, is I think the climate right now is much different than describing from your days back as a rep, where there might have been a budget surplus at the end of the year or something like that, and the hospital was looking for other things, or a division or a department was looking for other things to get to make sure that they kept that same budget level, going forward. Particularly with whatever the current climate and everything else like that, just hospitals aren't as profitable as they once were, and hospital systems aren't as profitable as they once were. And so at this point, almost anything that adds more dollars and cents needs to be somehow justified, whether that's from a patient care perspective or a marketing perspective or a market share perspective, or new surgeons are going to use this new thing.
So Carl, same question we've asked everyone. You're now several years into it. I know that you were also very judicious with waiting for the things you asked. If it's not necessarily even instrumentation, have you asked for an APP? Are you about to? Because there's more than just instrument and technology that are resources that can help with your practice.
Yeah, absolutely. So your practice, remember, all of everything that we think about in residency and most of what we think about in fellowship is all about operative technique, operative ability, operative execution. But your practice, especially when you start, is a lot more time in clinic. And you've got to be able to optimize there and, manage these things. And, for better or for worse, early in practice, oftentimes you're taking care of patients that, perhaps aren't as well insured and have more social determinants of health that make it harder for them to seek or get access to care. Perhaps you don't have the healthiest patients. It's helpful to have somebody else to sort of help manage these folks with you. So just full disclosure, when I started my practice, I had an administrative assistant. So someone that would help answer phone calls. They also did my surgical scheduling and, helped with paperwork in terms of getting patients approved for insurance for their surgeries and things like that. But I think about a year or so into practice, I had picked up enough volume that I felt like I could really benefit from having someone help me, an APP help me in the office. And so there were several different things that were discussed. I also had a couple of partners that were early in practice and were also at a similar stage at the same time. And so what we did, our department was, looking at all of us and saying, man, hiring a couple of these folks for all of you at the same time is a pretty big outlay. We're not sure that's the best call right now. And so it was going to come down to some sort of like a tug of war between us to see who would get it. Or what we ultimately decided to do, which has worked really nicely, is that we hired a couple of people for all of us to share. And so they've created this pod model is what they call it. And so a couple days a week, they're with each of us in person, but on the other days, they may be with one of my partners seeing patients somewhere else, but they're still available on the EMR to answer messages. They're still available to help with phone calls or do prescription management or other things like that. So it's still, even if they're not sitting right next to me on a daily basis, I still have some help.
I want to echo some things that Carl had just mentioned. When starting a practice, we are so focused on the operative efficiency and the techniques, but the business aspect of medicine and clinical efficiency goes by the wayside or can. One of the important things that I felt when starting my practice was identifying what help I would have. Who's going to be in the OR with me? Who's going to be in clinic with me? How are my patients going to get roomed? Having started a practice, I also had an administrative assistant that was shared between the spine department at my facility that helped with insurance approval and authorization, scheduling patients into my clinic. But once they arrived in my clinic, for the first several months, I was on my own. I had a medical assistant who was not specific to myself, but who would just room the patient, take vitals, etc. But as I developed in my practice and became busier, I was able to request and ask for additional hands in clinic. And so I was able to hire a nurse who works exclusively with me, who helps to discuss preoperative templates with patients and what to expect, who helps to schedule patients again for clinic and answer phone calls. And I think that my next phase will be hiring a PA. And I think that as I progress through my career, I've asked some of my senior partners when it's best to hire a PA or additional assistants so that I have someone who's with me at all times, either in clinic or in the OR based on efficiency, and to decide how to best utilize. And I think that's a very individual discussion and based off of how busy your career gets and when it takes off.
Bryan, do you mind weighing in on this? Go back to your younger days when you were in straight private practice. All of us work at systems, and you now chair, a large system where, resources are sort of delegated from the top down. But in a private practice model, we don't have anybody here on the call tonight that represents that. But in a private practice model, obviously that's different. If you want help, you can get as much help as you want, but you've got to pay for it. Now, how did that work when you were in your private practice? And, those questions that Dustin's asking about, should I give it now or should I get it later, or, what have you?
Yeah, it really kind of depends on in your practice when you reach that, tipping point where it becomes beneficial, or it becomes an incremental benefit for you to have that extra staff, whether it's a nurse or, another APP. But in private practice, at least in the compensation model that I was in for, 17 plus years, essentially your APP was a cost center or a profit center, depending on how you utilize them. So, if you utilize your APP to, see new patients, to see consults, things like that generate revenue, and they're able to cover their salary. Let's just say they just cover their salary based on the revenue that they generate, then it's a break-even point for you, right? If they only see pre-op and post-op patients in clinic that don't generate any revenue because it's in the global period, if you utilize them a lot in the operating room, where they're actually a little more profitable being in clinic than they are in the operating room, and they don't cover their salary or hit their metrics, then that would come out of our pocket, our salary. So I would be funding the deficit that my PA did. If you use them appropriately and you knew how to generate significant revenue with them and it was above their salary, then that surplus went back to us as physicians after their bonuses were covered. So it can be a tremendous amount of help. Now, you could obviously argue, even if it comes a little bit out of your pocket, that they make you more efficient. They allow you to see more patients. They allow you to do more work. So it's not necessarily a one-to-one, trade-off, because you may be paying a little bit for, cheaper labor, so to speak, but it allows you to be a lot more efficient in what you do and be able to, bill at a higher level as a physician. So you really have to understand how it works within your comp model and really understand what that looks like from an economic perspective based on all those scenarios.
Just to branch off of your question, is there a best way to identify that tipping point?
Yeah, I think in any good practice, asking your partners and your financial, your CFO or something along those lines to be able to run the numbers based on, say, last year's historical data with someone else in your practice that's very similar. They should be able to get those types of numbers for you, or you could at least do the modeling, yourself. If you looked at, your numbers for a year and what the cost of an APP is, plus or minus a bonus, salary, benefits, things along those lines for what you're covering, and kind of realize when your practice has gotten, busy enough to be able to say, okay, I'm at this threshold now where I'm going to be able to at least cover an APP salary in my practice. So I think going off a lot of historical data is probably the best and the safest way to do it.
Great insights. Let's stay with Bryan. So department chair, I have to assume that you have a seat on, or you're at least called when it has anything to do with your department, on the value analysis committee. I think sometimes it's called new technology assessment committee. So if someone, well, first of all, for those out there that have never heard of this, can you share what that is? And then can you share the steps on how to prepare if you need something that has to go through that committee?
Sure. So it's different. It's different in every practice. I think you're right. Most hospital systems have, a new technology assessment or advisory committee, and every place does it a little bit differently. But most commonly in general, what you'll see is a group of surgeons with kind of diverse experience that sit on this hospital committee. You may also think of like a P&T committee with, pharmacy and therapeutics, but this is more geared towards, let's just say, orthopedics equipment, things along those lines. And when you have a request, then at least in the old system that I worked at, you actually had to fill out a form. You had to justify why you needed it. You had to predict how many cases you were going to do. You had to try and list the relevant data that was associated with it. So what's the clinical benefit over what is currently available? And obviously the cost that's associated with that. And essentially state your case in front of this committee that should in theory be unbiased and unconflicted. And if anybody is conflicted, they should recuse yourself. And also if you have conflicts, which may very well be the case and doesn't mean that you shouldn't be able to have access or be allowed to have that technology. If you do have a conflict, as long as you disclose that up front, and then it's essentially up to that committee to decide whether or not that type of technology fits with what their budget is and fits with what the vision is over the next year or 2 years. So that's the most common, I think, thing that we've seen, across the board. I know where I am currently, it's a little bit different because those types of expenditures come directly out of our orthopedic surgery budget. We still have to go through a capital equipment committee year over year. And depending on the cost of that equipment, if it hits certain thresholds, it can be approved within orthopedics. If it's higher, it has to go to the institutional level. So again, I think getting back to what we talked about in the beginning, particularly with Amy, you have to be very thoughtful about it. I've seen people come into those committees and it was very clear that their rep filled out that entire sheet and just tried to justify everything that was on there. So you have to be very thoughtful about it. What do you need? Why do you need it? How is it going to help build the practice in general? Does it add value? Does it positively affect patient care? And I think also in a sense, what hospitals and practices really want to know is, does it create a differentiator within the practice that's going to drive business? Because that's also an important part of it as well. And I think if you can check all those boxes, then you're more likely to be successful.
So this brings me back to the point, with Dustin, I guess if there's specific things that you need and maybe other competitive hospital systems are using them, you could use that as a reason to either keep up with the market and the savvy patients or try to outdo them, I guess.
Absolutely. I think that's very helpful to be able to make that marketing play, right? Because let's face it, that's what the hospitals are in business for, right? They want to draw patients in and they want to be able to differentiate themselves. So, there is certainly a mindset of either keeping up with the Joneses or being the Joneses, in those markets that I think is very appealing to hospital systems.
Bryan, back when you were in private practice, before you had this huge chair role and you were in charge of a entire department's budget, there was some capital equipment that you were asking for. And you did the legwork with your partners to make sure it got passed through. What do you wish someone had told you that you now know in the role that you sit as you were about to get ready to go into that and as you were battling to make a great case for why you needed that?
Yeah, I think it's understanding the ramifications of the whole department and the whole system. Right. I think to Carl's point earlier, we just assume, that hospitals have and make all of this money and it's just kind of free money that they can throw anywhere. And that is certainly not the case nowadays compared to what it used to be. So these individual decisions that you think may just benefit you may directly, indirectly have an effect on your department and also a little bit with your political capital, so to speak. Right. That's why I think being a good steward of technology and viewing this as a partnership with your hospital, as opposed to this is just me, I need this, I think if you go about it in that direction, you're going to accrue a lot of political capital that you're going to be able to utilize in the future. And understanding if you don't get something, or understanding if you're willing to kind of have patience and say, I'm going to defer this for a little while and make sure it's it's the right move, as opposed to you're requesting stuff year over year, and then all it's doing is just collecting dust in your OR. And in the long run, that's, I think, going to catch up to you. I think it's going to cost you some political capital for future decisions.
I'm going to go a little Game of Thrones here too. Remember also that you really want to involve your partners in these things for some of the newer technology coming out. If you're about to advertise that, that's going to shift a lot of attention to your practice. Your senior partners in your same subspecialty may feel a little threatened by that. So making sure that they're part of that conversation and bringing them along, to Bryan's point about political capital, is, sometimes the very person that you least expect it is the one that's torpedoing you from behind.
I don't care as much about it. I'm willing to forego that for this other thing that I care more about. Yet at the same time, the hospital may come to you at some point in your practice, and this has happened to me, where the hospital says, hey, we're trying to do X, Y, and Z. Can you help us out here? And by garnering that capital, by having that reputation, they recognize that you're, a reasonable person that they can come and talk to about something. And that, again, gives you more of a leg up the next time that you want something that you can, my point is that it can go both ways and it can be mutually beneficial to both.
So I'm obviously a hand surgeon, and there's not a huge capital thing. I don't have a robot for my carpal tunnels as much as I would like to. So the only time I have kind of run into some problems is with implants. And to be honest, it doesn't really matter to me. A volar plate for distal radius is very similar for most companies. And it's all about kind of what reps I work best with, or what are the most reliable. But at the same time, I don't want to confuse the OR staff. I don't want to spend the political capital, asking for certain implants. And that's been a little confusing for me coming in as a new surgeon. Because, for example, I like X implant. And to me, it's approved. So, okay, we can use it. And then 6 months later, they're telling me that it's the most expensive implant they have. And I'm like, wait, what? I had no idea. So I don't know if y'all have any advice as far as how to come in, what implants we should ask for. Should we just use whatever's on the shelf?
I think that's a great question and a great, way to think about it. Because oftentimes I think as surgeons, especially early in our career, we're not very well versed in the cost and what things actually cost. We kind of all just assume they're relatively the same, things along those lines. But I do think if you're actively engaged in that process early and going, because these decisions are made at a certain level, administrative level, and they may or may not involve physicians. They most likely involve physician leadership, but they may not necessarily involve people that aren't in those positions to be privy to that information. But that's where I think, being involved in getting on these types of committees early, getting put on one of those, either the new technology committee or something that has to do with how they decide the cost of implants or the cost of, plates or other types of medical devices. You will learn so much from being on those committees early. And then you'll have kind of an inside track, to all of that. Because you're right. If they're more or less clinically equivalent, but there's a big price differentiator, I think it's hard to justify that unless the service, especially early in your career, right? The service that some of these companies provide is really an intangible thing that we tend not to ascribe cost to, but is so important to you and how your day-to-day efficiencies run, right? You could decide to use a plate that's a little bit cheaper, is just as good clinically, but if the service from the company is horrible, that's not good for anybody. That's not good for anybody. But I think getting involved in a lot of those committees early will make a big difference.
That's honestly great advice. I've been trying to get it more involved because also when you're an early career surgeon, you're so focused on taking care of patients, one, but also just getting in your flow. You're doing boards. You've probably just moved to a new city. So you just get so wound up in doing, Monday. And then after Monday, you do Tuesday and you're going through the week. And a lot of times I'm just trying to figure out how's the best way of getting to know other physicians outside of orthopedics in the community. And then also just, I don't want to be an administrator, but I do like to understand these decisions that are being made. And they're being a part of some of these podcasts or different conferences has been great, but locally as well, I just want to kind of understand how hospitals work. And I didn't have that education when I was a resident. So I actually like that advice. And that's kind of a little motivation to figure out what committee I could get on.
Yeah, nobody does. And that's why these courses like FPA are so important. But you get through your boards first. That's most important. And then you'll be able to kind of branch. It's like you said, you don't want to be an administrator, but we certainly don't want them making all the decisions, which is why it's so important that we populate these types of committees.
Well, this has been a fantastic discussion, everyone. Thank you so much for your very candid feedback. And I'm sure there's a lot of surgeons out there listening in that are writing notes and they're really prepped to go ask for that thing when appropriate. Thanks for listening to this podcast brought to you by the Foundation for Physician Advancement. You can find more great content on our YouTube channel at Building a Successful Practice.